most of the policies that I've been talking about, paying providers, changing coverage for patients and consumers, are based on a very simple economic notion that people and firms optimize, that they do the best they can with the constraints they have, constraints of income, constraints of other resources. But those kinds of models have actually fallen a bit out of favor in economics, and in particular in the sphere of policy design. There's a great deal of interest in so-called behavioral economics. So what's different about behavioral economics that matters for this purpose? Well, in behavioral economics, there's a relaxation of that assumption that everybody's doing the best they can all the time. And so in particular, we have this idea that people, while they are making calculations systematically about what they want and making choices systematically, that those aren't always optimizing. So it's not that people are randomly deciding whether to go to the doctor or not, but they may have some biases in their decision making that we could understand and use in policy design. And so in particular, there are a couple of sources of biases that are going to be important for thinking about health policy. One is that we know that human beings have trouble processing large numbers of options. So that would include both physicians and patients. If you give them a lot of choices, they may actually make worse choices than if you give them a few choices. And it's also true that people have trouble making choices that have different consequences over time. So a classic one, of course, is saving for the future, that people don't always make consistent choices when they think about the future. Another bias is that people really like what they have in particular, and they are particularly averse to losses in a way that's not symmetric with the way they look forward to potential gains in terms of things that they don't have. And so again, these are all insights that can help us design policies in ways that are more consistent with human behavior. So one place where behavioral economics tells us to look is in terms of heuristics that individuals use to make decisions. So these are rules of thumb. And so we know from our own behavior that we don't go out, for example, and look at every possible option when we're buying a new car, when we're choosing a health insurance plan. And so here I'll give you some information about health insurance plan choices. This is a very popular policy now, is to give consumers more information about the quality and cost of their health plan, the quality and cost of their doctors. And so we developed these big report cards with lots of domains of measures of quality, so very complex. And then some of the providers who give these report cards organize that information in ways that doesn't mesh very well with individual behavior. So here's one report card where you get all your plan choices alphabetized. So we know one rule of thumb that people use is pick the top plan or pick the top choice. It's easy, it's at the top of the list. So in this case, we have a health insurance plan, not to be named, that begins with the letter A. And so we worry, and in fact, research shows that people are much more likely to pick the A plan if you alphabetize them than if, for example, you sorted these based on quality, based on geography. However they're sorted actually affects what people choose. So we need to think about that. Optimization may not be the rule here. Something simple may be the rule. Then there's another important phenomenon called the status quo bias, that people they're likely to avoid a choice where they can, and so they favor wherever they are now versus any other option to a degree that is not optimal. And so the way we can think about this in terms of designing policy is when we give people an active choice, we might sort of force them into a starting point that is the answer that policymakers think is likely to be best for that person, and use status quo bias in a way that encourages those good choices. And so again, retirement savings is one place where these defaults have been used, but you could also use this in health policy. So for example, for physicians, if we put defaults into their treatment protocols in their electronic medical record, the delivery system could, for example, make the appropriate drug, the best drug, the default, and the physician always has liberty to change that, but they'd have to make an active choice to move away from that recommended drug. Another place where this has been used in policy is in organ donation. So we're all familiar with those organ donation programs, and there have been studies that looked at different countries and their policies for organ donation. Some countries required patients to get the card, put it in their wallet, and say, I want to be an organ donor. Other countries said everyone's an organ donor unless you opt out. So the same choice, different default position. And so you can see in this chart that if we require people to make an active choice to donate their organs, they're much less likely to sign up than if we require them to opt out. And really, it turns out that that opt-out position is similar to a very neutral delivery of that information. So defaults matter. People worry a little bit about paternalism in setting the defaults. So how we set that default really needs to be some process of legitimate decision making, but clearly they can be very powerful. Those insights can be very powerful, not just for correcting what we see as problems, but for moving the system to better outcomes. Loss aversion, as I mentioned earlier, is this idea that people feel more strongly about losing something they already have than about getting something they don't have. So in a classic experiment, really the founders of behavioral economics, Kahneman and Tversky, did an experiment with students where they randomized the students. One set received a mug, one set didn't receive the mug, and those with the mugs had to decide how much they would sell their mug for. So what's the least amount of money they'd be willing to sell their mug for, and those without mugs had to decide how much they would pay for it. And of course, these mugs came out of the ether. These were not possessions of these individuals 5 minutes before class. And even in this circumstance, we see that what the buyers were willing to pay was dramatically less than what the sellers were willing to sell their mug for. Similar experiments over time have shown again and again that once you have something, you really want to protect it. And so there are lots of good ways of thinking about doing this. Going back to pay for performance, so we may not be able to penalize providers for not delivering high quality care, but we could give them $5,000 and say, if you don't reach these quality measures, we're going to take it back from you. So that's just a design with very similar kinds of reimbursement consequences, very different kinds of behavioral consequences. So economic models are mostly useful to the extent that they predict behavior. That's how we use them for policy development. Where economic models don't predict behavior well, where we have so-called bounded rationality, people making choices that may be predictable but may not be optimal, then we really need to use those insights from psychology to design better policies. Healthcare is a great place to think about these issues because it is so complex, because there are lots of issues, psychological issues, such as the potential for regret. If I make this active choice, am I going to, for example, regret the consequences of that surgery or making another choice? This is where behavioral economics really comes into play. Thoughtful design of incentive policies, in particular for both patients and providers, can lead us to much better outcomes.